The sign-in code for this presentation is 7272.
For those of you who I haven't met yet, I'm Dr. Sara Mulholland, Vice President of Expansion here at Full Spectrum. Started as a provider in the field, and now I work in the corporate office working on expansion into various states. Currently, we are also open in South Carolina. For today's Journal Club, we're going to be talking about autism and puberty. Selected this topic for a couple of reasons. First of all, the word puberty puts fear into pretty much every parent out there. And for us as providers, working with children with autism who have communication challenges, behavioral challenges, the thought of the changes that happen with puberty can be pretty overwhelming. I selected 3 articles to send out that I sent out. Hopefully you all had the chance to review those. 2 of them were specifically about challenges with autism and puberty, and another one was about the concept of precocious puberty, which we'll talk about here in a little bit. So if any questions do come up, feel free to just speak up or put them in the chat. If you haven't attended one of my presentations before, I like a lot of interaction, so I will ask questions here and there. So as far as the task list areas that we'll be touching on today, for the analyst task list, we have F3, identify and prioritize socially significant behavior change goals. We also have H3, recommend intervention goals and strategies based on such factors such as client preferences, supporting environments, risk, constraints, and social validity. And H5, plan for possible unwanted effects when using reinforcement, extinction, and punishment procedures. For the RBT task list, we have C5, implement naturalistic teaching procedures. We have C10, implement generalization and maintenance procedures. And then we have D3, implement interventions based on modification of antecedents, such as motivating operations and discriminative stimuli. And then finally, for the ethics code that we'll be addressing is providing effective treatment. So this is just a word cloud about puberty, so words that tend to come in mind. Fair warning, you guys are going to hear the word sex a lot in this one today because that's part of puberty. So the word puberty, like we said before, could be a little scary, but all it means is the child's body is physically maturing into an adult. They are now capable of sexual reproduction. For most individuals, this happens around the age of 14 for boys and 12 for girls, often accompanied by emotional and/or behavioral changes. So the first article was the Remington article, and it was called Puberty Challenges for Adolescents on the Autism Spectrum. This particular article was a literature review of the literature out there regarding puberty for children who enter adolescence. One thing that was found is there's not a lot of research in that area at all. So this particular article looked at literature starting from 1981 through 2016, just to find enough to do a literature review. So some things that it found is, of course, as we know already, puberty can be tough for a child at any age, but it's compounded by deficits with ASD such as communication, social skills, and problems with daily living skills. There were several studies that talked about puberty in children and their siblings starting earlier than neurotypical peers, specifically in girls. I found it really interesting that it was the siblings also, even though there was no genetic component. That was primarily with girls. It happened some with boys also, but most of the literature found that that's more with girls. So they identified themes from a literature review from 5 families. A lot of the study sample sizes are also very small for this particular topic. So themes they found were a need for routine, but also that the households were often changing their routines to avoid behavioral concerns from their children during puberty. They were also making additional accommodations for the children during that puberty time to avoid those behaviors. Potential concern for that could be losing some learning skills because they're just trying to do anything they can to keep those behaviors from happening. All right, so continuing with the Remington article, they reviewed a study, from 1,609 participants. This was the biggest sample size that was found. 435 of them were adolescents with an autism spectrum disorder diagnosis. They did find that behavioral concerns increased significantly during puberty. However, they noted that the study didn't talk about how frequent those behaviors were before and after puberty, so it was really hard to make that direct connection. They also found that there is a lot more social adjustment concerns for the children with autism as opposed to neurotypical peers. Whereas we know that children in general are going to have some social adjustment during puberty, but for those with autism, it was more difficult. There was also some female-focused studies, so specifically about females with autism in this literature review. So they used a thematic analysis after conducting semi-structured interviews with the families as well as doing some focus groups. They found differences with menstruation onset as well as sexual vulnerability were two of the biggest findings from those studies. Menstruation onset was earlier than neurotypical peers for the females with autism. And they also found that those females were more sexually vulnerable, primarily due to lack of education and knowledge and some of their social struggles. They also found more isolation in this population because of those struggles with the social realm. There was also a lack of understanding. And what this meant is, especially with females, a lot of us know that there's a lot of passive aggressiveness between females, especially in like that middle school, junior high, high school range. Females tend to have more relational aggression than physical. There also tends to be gossip and exclusion, and children with autism often don't understand this. So those passive aggressive behaviors, rather than someone just getting in a fight, as a lot of the males tended to do more, they had more direct aggression, but that passive aggressive behavior underlying those relational issues, the kids just didn't understand that as much, so that made it more difficult for those with autism. There was also an issue with PMS symptoms. The kids with autism were not really reporting those, so an escalation in behavior was the indicator that they weren't feeling well, that they were uncomfortable, they were having cramps, whatever that was. Any questions so far? Yep. Thank you, Michelle, for sharing. Michelle said that when she was 12, she needed to rely on routine to help ease herself from those changes that were occurring, which makes a lot of sense because everything feels so new and different. Thank you for sharing that. I appreciate that. The next slide is going to be from a study of 100 adolescents that really just solidified some of these themes. So the categories we're going to talk about are sexual behaviors, sexual selfhood, and sexual socialization. So sexual behaviors, some of those themes that were found are commonalities, particularly with that group of 100. They found that one of the biggest behavioral concerns was masturbation in inappropriate settings, such as in public. 23% of the parents interviewed reported their children had done that. And 65% reported inappropriate touching of self in public. So maybe not true masturbation, but still inappropriate touch. 18% reported their kids inappropriately touched other people. 14% reported that unusual masturbation aids were used. So these are items that they use to masturbate with. 25% reported some type of paraphilic interest. For those who are not familiar with that, a paraphilic interest is an unusual sexual preoccupation or interest that would be considered out of the norm and often considered deviant. They found that this was most common with those who had an intellectual disability or higher severity of ASD symptoms. They also found what's called counterfeit deviance, which we'll be talking about shortly. Sexual selfhood, this is more about knowledge base. So that's what they mean when they say selfhood. So for sexual selfhood, they found that the children with autism tended to be very naive when it came to sexual topics. They were also overly open about those topics because they didn't really understand what settings are okay to talk about these things and what settings are not. they had a very low concept of how their behaviors affect other people. So if they did touch themselves in public or inappropriately touch someone else, they didn't understand why that was a problem and that affected other people. They would often confess to deviant behaviors. And I say confess in quotes because it's hard to know if, one, if the behavior is truly what they did, and two, was it truly deviant? And again, we're going to get into that concept of counterfeit deviance here in a little bit. They also tended to be very sheltered, which limited their knowledge of sexual concepts. A lot of times the parents of these children with autism don't really think about sexual education as something they need to be talking about, or those type of boundaries, because the other delays make the children seem so young that it's easy for the parents to forget this is something I need to be talking about because physically they're this age. They also found a lot of concerns with hygiene. So being able to take care of themselves hygiene-wise due to the changes in their bodies for puberty. And then finally, sexual socialization. Often these children were learning by observing other people, and I put that in quotes because they're not always learning appropriately, because they're observing peers or they're seeing something on TV, something in the media that has sexual content. And this is how they're learning because they're not getting the education they need. They're also not aware of which models are appropriate and inappropriate to model their behavior from. A lot of concerns with boundaries. So again, that inappropriate touch that I talked about before, just not understanding that's inappropriate. They would talk about inappropriate topics or make inappropriate statements as well. So looking at the Remington article, they did recommend some interventions and supports. The first one was autism-related social skills training. So they said, keep using the social skills approaches that we use that work with autism, but make sure that you include some form of sexual awareness. This does not mean that we're giving sex education. Don't do that. That's not your job, not what you're qualified for. But awareness as far as we don't pull our pants down in public. You know, we don't touch people without asking, those kind of things. So those sexual boundaries that maybe they really haven't been exposed to much, making sure we incorporate that in, as well as talking about hygiene skills and related to puberty and those changes that are happening. They found in this literature review that when we used the social skills training overall, including these topics, that was a lot more effective than trying to do direct sexual education with this population. They also said use multiple approaches and settings so that we can really help with that generalization, just as we do with other topics that we're teaching. Next is overall education, both social and sexual. This is more about avoiding becoming a victim or a perpetrator because of their behaviors. So children with intellectual disabilities, autism, anything in that realm are much more likely to be victimized because of that lack of knowledge of who to avoid, that this type of touch is not okay. Don't let somebody do that. They're also more likely to engage in what could be considered perpetrator behaviors. Again, not because it's sexual, but because they don't understand that that is a boundary not to cross. They also struggle with some social dynamics. So making sure we're including this knowledge in that skills training is essential. We also need to give the caregivers support. This is a tough time for them too, because they're trying to navigate the fact that their child who, maybe intellectually or socially is much younger, is physically of the age for puberty and going through these very age-appropriate changes while everything else seems delayed. And that can be very difficult for those caregivers. So we need to support the caregivers on how they can make those behavioral changes and incorporate those interventions to work on these skills for the children, just as we do for regular parent training. Make sure that we help them know how they can support and educate their children, and that it's okay to answer questions about these things. It's okay to use words like period or penis or whatever is going on. Those anatomically correct terms is okay. And have empathy. Understand that this is difficult for them and be able to be there as a support in our role as analysts, RBTs. And finally, hygiene education was recommended. So we can use things like social stories to help them understand appropriate hygiene for these new changes that are happening, make sure that we're finding ways to practice, and incidental teaching. So if you have a female client on your caseload and she happens to be on her period, then that's something that we can be coaching, mom about or dad about, whoever the caregiver is, as far as, okay, let's make sure that they're changing their pad. Here's a task analysis on how to change a pad, how we walk them through that, making sure that we're assisting in those areas. So sounds like it's definitely showing up for some clients. Yeah. And I've been working with some analysts who have clients going through the same thing, and my daughter is too. So felt like a very appropriate topic to address. I'm glad you're finding it useful. So now we're going to talk about the concept of counterfeit deviance. So counterfeit, as you know, means something that's fake. Deviance, in this case, sexual deviance, tends to be behaviors that are not only out of the norm, but they also cause harm to others. So they're not just unusual, they're harmful. And we say counterfeit deviance. I'm going to go into that actually here in a minute. So some examples of sexually deviant behavior: public masturbation, inappropriate touch of others, those paraphilic behaviors that we talked about before, undressing in the presence of others. These are all considered deviant behaviors that we may see children with autism do, especially during times of puberty. And that's just a few examples. There can obviously be several more. So when we say counterfeit deviance, a lot of times you'll hear providers say, wait, sex is sex. If they're doing something sexual, it's sexual. And I will tell you, from my years of working with sexual offenders, we were always taught that when we worked with offenders. There's always a sexual component. Not true with this population. So even though we're told that a lot, we know that human beings are sexual beings. That's just part of being human. Doesn't matter if you have ASD or if you don't. But that does not mean that all humans are engaging in sexual behavior for sexual gratification. With this population, we tend to see deviant behavior, but the function is not sexual. So some examples, all four functions that they can fall into. Escape, it could be that they're avoiding a person or a situation or an activity. Access, they're trying to get access to another area. Hey, if I do this, they're going to tell me to go to that room, and I want to go to that room. Attention, trying to get attention from other people, getting reactions from others that they enjoy. And sensory could be relief of discomfort or finding comfort. So some examples that I've actually seen from working in the prison settings as well as in the group homes, actually worked with an individual who came to us, an adult, when we're working in the group home, and he'd been kicked out of his last group home for grabbing the penis of other males that he had roomed with or he had been in the same home with. And after he had been where we were at and we had lessened a little bit of the restrictions because he was doing well, he ended up touching the penis of his roommate and had to be moved from one home to another. And as I looked into that, because then he got put onto my caseload, because anytime something sexual came up, they were like, hey, Sarah, come deal with this. As I really looked into his records and what was going on, I realized he did it because he did not like the roommate. And he has learned over time, if I don't want to live here, or if I don't want this person to be in my room, all I have to do is touch his penis. So then we had to work with him on other ways of saying, hey, I don't like this person. I don't want to spend time with this person. I need space. And once we started teaching that to him more, because he was verbal enough to do that, the sexual behaviors went down dramatically. Some other examples, we've had someone, like I said before, they might be touching somebody else so that they're given that replacement item. They might enjoy the fact that other people are reacting. They think that's funny. Or again, that physical part. When girls are in puberty, sometimes they have the sore breast area. So maybe they're touching themselves there because it hurts. Boys, erections are weird for them. They don't know what's going on there. So it kind of makes sense that they might touch it. Or they might try to make it happen because it's something different and it feels different. not sexual gratification. So the next article was the Hamden article. And this one was about changes and challenges of puberty in adolescents with autism spectrum disorder. This one was actually a qualitative approach, used semi-structured interviews. This one was not a literature review. It had some literature review in it, but the overall article was a specific study. So they interviewed 12 parents, 8 men, 4 women. All had children from ages 13 to 18 that had autism diagnoses. Interesting part of this article was the cultural awareness. So you may have noticed that some of the article was written in a different language before it went back into English. So this particular article is from a Saudi Arabian country. So some of the cultural awareness, they had to have males interview the fathers and a female interview the mothers because that was culturally acceptable, not mixing the two. They also had to vary their interview settings and formats based on the comfortability of the participants based on their cultural values. So I thought that was an interesting thing to note. However, a lot of the issues they found for puberty were very much the same. So they identified those common challenges for puberty with autism, specifically from the parental point of view. Of course, since it is a small sample size, it limits generalization, but it does verify a lot of what we just saw in the literature review. So some themes that were identified in this one, they identified some risk factors for struggling with puberty, so things that indicated that the struggle might be more difficult. They identified behavioral challenges, physical challenges, and psychological challenges, all related to puberty and autism. So risk factors, the more significant the communication deficit was, the more likely the child was to have some struggles with puberty. Also, if they had comorbid health or physical problems, that was more of an issue. Their behavior concerns before puberty affected during. Lack of education, so not really being talked to about this topic. How severe their autism symptoms were, as well as if there were any intellectual delays present. All of those things indicated that puberty was going to be more difficult for those individuals. And then behavioral changes. So interesting, they found a lot of those stereotypical behaviors, and repetitive behaviors actually decreased during puberty. However, they returned later. So I found that very interesting. 42% of the sample, self-injury completely stopped and did not come back, at least not during the study time. They found an increase in aggression and anger-related behaviors, so a lot more frustration and taking that out physically. They also, as expected, saw some increased sexual behaviors. They also saw shifts in rigidity. And what I mean by that is the individuals who needed that rigid routine and structure still needed it, but the way they needed it may have changed. So they still needed their structure, but they needed a different structure than they had before. Physical challenges, hygiene deficits, just like we talked about before, for both boys and girls. Girls taking care of menstruation, boys taking care of when they have wet dreams. Things that they just didn't understand, and therefore didn't understand the hygiene needs associated with those things. Just like in what we saw in the study before, puberty onset was earlier with the girls who had the autism diagnoses. This one didn't mention siblings, but it said the girls who had that diagnosis, puberty did start earlier. However, the children who had severe ASD symptoms or intellectual disabilities, their puberty started later. The physical changes required just shifts in their monitoring and behavior. A big thing that came up often was shaving. Just that concept of having to shave was very difficult for a lot of the kids in the study. Psychological changes, social withdrawal was a big one. Tending to avoid places or situations that maybe they didn't avoid before. That lack of awareness of, social expectations, understanding social cues was causing more of an issue with their peers now than it had before, again, because their peers are also in puberty and going through those changes and understanding some of those cues that the kids with autism were not. Significant mood shifts, especially towards anger. They also saw regression in skills, particularly in the hygiene area. So kids who had showered just fine before were now averse to showering. Kids who had been independent in things suddenly weren't doing things like selecting the right water temperature for that shower or brushing their teeth. So a lot of regression was happening in those activities of daily living. Also seeing some changes in their attitude towards food. So we know a lot of times kids with autism can be selective with food, but it changed. So maybe they were eating more or their selectivities changed. Yes, functional communication training is a big, big part of this, Michelle, 100%. The Hamden article also looked at some gender-specific changes that they found regarding autism and puberty. So for females, they found, like we said before, their age of menstruation was significantly earlier in the females with ASD. On a personal note, I will tell you my daughter, who just interrupted us a little bit ago, she definitely started significantly early. She was just barely 10. And I remember thinking that that was so odd. And then as I learned more about this, I realized that it's not because she has autism. The menstruation often was longer in their earlier cycles, and it would also take longer to regulate. So a lot of times girls, when they first start menstruating, those first couple of cycles are light and fairly short. Hasn't been the case in these studies for females with autism, and took longer to regulate as far as that every 28 or 30 days, whatever it is for that particular child. They struggled a lot with menstrual hygiene. So that was a big struggle for them, which can cause some health problems. The PMS symptoms were significantly problematic, partially because they couldn't communicate what they were, or because they were more severe, and they would have some behaviors as a result of those. Social withdrawal became more of a concern, and those stereotypical or repetitive behaviors tended to fluctuate or change with the girls. The male-specific findings, there weren't as many, but there were some there. Increased aggression was a big one. The concept of wet dreams and the hygiene about that was very difficult for the boys. Shaving was a lot more of a concern for the boys than the girls, particularly having to shave facial hair caused a lot of significant sensory reactions. They had more issues of inappropriate self-touch and a lot more of the anger outbursts. So recommendations from the Hamden article. Also talked about skills training, specifically autism-related skills training, but incorporating skills related to puberty, hygiene, all those changes that are happening, the social skills. They also said skills training for parents with a focus on puberty changes is needed. So really being very direct with the parents who probably don't want to talk about it. And I'm not saying you force them to talk about it, but you open that door and say, hey, I know the child is at this age. There are probably some struggles there. How can we help? What are you seeing? So that we can open that door and really help the parents support that for a topic that tends to be taboo. Counseling and support for the children and caregivers, obviously that is not our role, but we can recommend it as an additional support. And making sure that we focus on family dynamics and support. So puberty is actually a family problem. You know, it's natural, but it causes issues for the whole family, not just the child who is experiencing it. So Hamden was saying make sure that we recognize that. So the last article, I am not going to try to pronounce his name, but there it is, was about central precocious puberty. Some of you may have heard of that, some of you may not. This particular article looked at two girls with this diagnosis who also had autism spectrum disorder. The first one, she was 7 years and 9 months old at the time of the initial study and, of course, had that ASD diagnosis. She started having physical signs of puberty at age 7, which means she was developing pubic hair and breast buds. On the Tanner scale, she was between 2 and 3. And I'll show you what that Tanner scale is after that slide for anyone who has not seen it. She did not have any comorbid diagnoses, so nothing else that would explain puberty starting early. There was no family history of early puberty either. They were concerned with her starting puberty so early because of just some medical factors when they were looking at her growth. So they had a projected of how tall she should be based on her genetics, and she wasn't there yet. And growth tends to slow down, sometimes even stop during puberty. So they were concerned that she would have some stunted growth physically as well as possibly cognitively, emotionally. So she was treated with the GnRH analog therapy, which is an approach that is to delay or interrupt puberty. It's actually some of the same type of medications they give for things such as endometriosis or similar diagnoses that help basically stop that hormone production. So at the time the study was published, the girl was 8 years and 6 months old and had not started her menstruation yet, and she had grown a little taller. So it looked like the treatment had helped interrupt that enough. The second child was 9 years and 8 months old at the time of this study. She also had that diagnosis of autism. She actually had physical signs of puberty at age 7 as well. It just wasn't reported to a doctor until she was 9. Also had the pubic hair and breast buds as those initial stages at age 7, Tanner stage 2 to 3. They did a scan on her and found, however, that her bone maturity was reading that of a 12-year-old. So they weren't as concerned about her growth, and she was pretty close to where she was projected to be. They also felt that she had really poor support for medication compliance. They didn't think that she would be able to be compliant with that, so they did not give her the medication. She did end up starting her menstruation at the age of 10. You never heard of that puberty before? A lot of people haven't. Usually people don't hear about precocious puberty unless it comes up, like their own child is starting signs very early or something to that effect. But it was actually found that it's a lot more common in girls with ASD than neurotypical children in general. So this just shows what those Tanner stages are, just so you can see them. There's one for girls and one for boys. So the Tanner stages talk about development, physical development only. So stage 1 for girls is elevation of the papillae only, may only have just the very light, thin hair that you barely see, what we kind of call peach fuzz. They grow about 2 to 2.4 inches per year, and they are starting to have some ovarian growth. Stage 2, so the two girls we just talked about were stages 2 and 3. Stage 2 is when the breast buds do start. They might have a little bit more hair on their labia. They're growing 2.8 to 3.2 inches per year. And they have some other physical changes there. I'm not going to read them all to you. I'm just reading the ones that were with that article. Stage 3, more breast tissue growth, but they're not really fully formed yet. They're having coarser hair. That pubic hair can grow 3.2 inches per year. You'll see after stage 3, the growth slows down significantly. So it goes down to 2.8 inches per year in stage 4. And stage 5 is when they stop growing completely. And that is when they have adult hair. They may have to start shaving their legs and that kind of thing. So that's why they wanted to slow down that one who wasn't growing as quickly and was starting so early, because after stage 3, that growth slows down and they didn't want that to be interrupted. And you can see we have that for the boys here also, that can be reviewed in the PowerPoint. You can see also boys, same thing, do tend to grow. They actually continue growing longer in girls. So in stage 4, they're actually growing up to 4 inches per year, which is why you see the boys kind of shoot up in high school. So with all this information, we need to talk about what that means for us. As behavior analysts, as RBTs, we're working with these kids. And day in and day out, a lot of times we're seeing them almost as much as their teachers or whoever else is involved. So we definitely need to be able to support them and the families. So first of all, we need to be aware of their changing needs. We need to know that these kids are having changes in the areas of social, emotional, behavioral, and physical health. So we may need to really be aware of those changes, support them more in one area or the other than we were before, as far as those skills that we're teaching or those behaviors we're intervening on. This is also prime time for spontaneous recovery. So a lot of those old behaviors suddenly coming back, and we're like, wait, where did this come from? I'll give you an example of my daughter again, because I swear she gives us examples for everything at some point. Just a couple of weeks ago, she tried to beat up her teacher. She hadn't been aggressive like that in years. Ended up, she was starting her period. So spontaneous recovery associated with puberty is very, very common. We need to avoid assuming that something is deviant or has an offending type motivation. So again, just because the behavior is sexual doesn't mean it is sexually motivated. We still need to be looking for the function of the behavior like we do for any other behavior. One thing I have found throughout my career is people hear the word sex and everything changes. So we were talking about behaviors. Oh, it's fine. Oh, but it's sexual. Now we have a problem. You know, we need to do A, B, and C. Behavior is behavior, whether it's sexual or not. And we need to address it that way. We're looking for what is the function. That individual I told you about at the group home, he just kept getting kicked out of place after place. They're like, well, he's a sex offender. No, he wasn't. Okay, legally, definition, technically, yes. What he did was an offense, but it wasn't sexually motivated. And once we figured that out, we were able to work with him so that he wasn't doing that anymore. Just like aggression, just like self-injury. You find the function and you deal with it as a behavior. We need to make sure that we're tailoring our skills programs to include puberty-related needs. So be ready to shift that behavioral focus when that spontaneous recovery happens and go back to whatever we had to use for that to be consistent. Be ready to use new approaches for social skills. Be ready to generalize to new settings for new behaviors and skills that they're learning to help them incorporate that. Have that open communication so that we can talk about social changes that are happening for that child so we can address those needs too. We also need to know that puberty is probably going to hit sooner than we're ready for with these children. Parents aren't ready. We need to be ready so that we can help support that and also help support the parents who were not ready to deal with this with their child who is functioning more like a 5-year-old, but body is turning into that of a 12-year-old. Going into that, parent training. We need to be able to teach parents how to support their children. They need support as well. Help them navigate this. Give them social stories they can use. Give them, some skills training that they can implement at home when we're not there to help support their children, just like we do for any other behavior and any other skill. Make sure that you're aware of your own biases and comfort level. If during this presentation, the amount of time I have said the word sex has made you uncomfortable, look at that. Because if you're working with children in this age range, it's going to come up. Again, you are not sex educators. I'm not asking you to do that. Do not do that. But know that these kind of issues are going to come up. So you need to assess your own comfort level so that you can support appropriately. Make sure that you get comfortable with what your role is. Ask for more supervision or support as needed to really find what those boundaries are. What is my role? What is not? And what am I comfortable helping with? And what am I not? If you're not comfortable helping a girl learn how to take care of herself during her period, you need to be telling your supervisor that so that we can work with that. Maybe we need to switch providers. Maybe you need more training. It depends on what you two talk about. Not asking you to touch it. Nobody's asking you to touch it. But you may need to help walk them through those steps. Be ready to revisit previously mastered hygiene goals. A lot of them come back. So it may be the kid was great at washing their hands after going to the bathroom all the time, and now suddenly they're not. Don't get frustrated. We just teach it again, especially when it comes to new hygiene needs related to puberty. And finally, stay in your lane. Like I said, we are behavior interventionists, right? We are RBTs, we are analysts. We are working in the ABA realm, and that is where you stay. So make sure that everything that if you're an analyst and you're doing goals, make sure those goals are behavior skills related, intervening on those behaviors or those skills that fall under the ABA umbrella. Make sure if you're an RBT that you're not trying to give advice about something else to the child or to the parent. You are focusing on the area that you are trained in for this child. If they do need additional support, additional education, or a counselor, we give them resources for that. Do not take that on yourself. And I wanted to leave plenty of time for discussion. So, questions, discussion. Anything in here surprise you, or anything you feel like you can use in the field? Thoughts about teaching social skills versus stranger danger related to using a public restroom. That's a good one. So stranger danger is also, that's a tough concept because we don't want the kids to be afraid of people, but we also want them to know boundaries such as like safe person versus non-safe person. And when it comes to using the restroom, that is, a difficult thing to teach as well. I think one thing you would start as far as a public restroom, first of all, would be teaching them basic things like closing and locking the door when they're there. You have to close the door before you pull your pants down. Not talking to other people in the bathroom because some kids like to talk to everybody. And really talking about, who can take you into the bathroom. So it's okay if mom takes you in there, but you don't go with somebody that you don't know. So really just looking at how you address those boundaries in general socially and just making them more clear for those specific things such as a public restroom. Michelle says, I would use a lot more with modeling and skills training for client and parents on this one. Topic can be tough for the clients, not just parents. So true. Thank you. Taught an ASD unit, self-contained classroom. Wish I had this information for sure. Yep, and the boundaries. Boundaries are so essential. We really need to be teaching that from when they're little. And I think that is something that we trip up on, not only as providers, but as parents, right? And people in general. Little kids run up to you and they want to bounce on your lap and you're like, yeah, that's fine. We're not teaching them then to ask first, or do you know this person? Those are things we need to start teaching them when they're like 3. Before I jump on you, can I ask, can I get in your lap? Something like that. But we tend to think, oh, they're so innocent, it's not a big deal, but they don't stay that long. And that is something I found working in this field in general, especially when I worked with adults, how many behaviors I saw adults doing that when a child did it, we're like, oh, it's no big deal because they're little. But we forget they grow up to be adults and they're doing the same thing if we haven't taught them differently. Okay, Shanita says, I feel like we can use everything you talked about, but being in the Zoom has taught me something about myself and comfort levels for sure. Yeah, I bet. Teaching clients safe boundaries, yep, what's safe and not safe for sure. And that can be especially difficult if you have a client who doesn't always answer correctly either. So that yes-no concept, which I work on with kids a lot, not just do I want this, yes or no, that's easy. But is this okay, yes or no, is a more difficult concept for a lot of these kids. So then you're trying to teach them boundaries, can you go with this person, yes or no? And they're like, yeah or no, but you're not sure if they really get it. So practicing it, role play, that kind of thing is very important also. A son nearing age 12, seeing a lot of physical aggression, some emotional outbursts, yep. Developed body hair this year, feeling better, knowing the behaviors are puberty related. I wish I knew they were temporary. With the child who busted in earlier, I wish that we knew they were temporary also. Oh my goodness. But we'll get through it, right? We just have to be consistent. As parents, just have to be consistent in those interventions and in those boundaries. And you may feel like a broken record when you're saying things like, no, you can't come out naked. Close the door when you're in the bathroom, those kind of things, but we need to. I've also found communicating with the schools is very helpful, especially if they are in some type of self-contained classroom or have a paraprofessional assigned or some other type of support at the school. Communicating with them when the children are having these struggles so they can get that extra support there is very helpful. I will say from what I have seen, the intensity of the behaviors during puberty does tend to die down. Just anecdotally, what I've seen, across multiple individuals working with adolescents and adults, the intensity does go down when their hormone levels, stabilize. Just think about any of us, if our hormone levels are off, we're reacting differently. So are they. They just don't know how to communicate it. We're actually joking about when my daughter tried to beat up the teacher a couple weeks ago. The whole thing is she was upset because she wasn't allowed to have the popcorn snack because of some behavior she had right before. So she couldn't have the snack right then. So she hit a kid who got the popcorn, and then she went after the teacher who said no. And we were joking about it. We're like, man, she just needed something salty, and she needed it now. And we laughed about it. But at the same time, that was probably true. And she didn't know how to say, I'm craving something salty. You know, I feel like I need that, and I don't know why that's just so intense. PMS symptom. Yeah, most are uncomfortable talking about the topic, but it's important. So true. Our society in general doesn't like to talk about sex. For as sexualized of a society as we have, people don't like to talk about it candidly. You hear a lot of the jokes. You hear a lot of people, you know, like making fun about it, or, you know, inappropriate type behaviors that you might see out there. But when it comes to actually having a real conversation, people are very uncomfortable. And I think that's why we joke about it so much. There's the references, just so you have them, but I know I sent all those out. So I'll hang out as long as there are people still in the room that want to chat. But other than that, you guys have a great evening.
The sign-out code for this presentation is 3722.